Good evening. Today I will take a class on acute lymphoblastic leukemia. First of all, the definitions. Leukemia are the neoplastic proliferation of hematopoietic stem cells and the cells of its different lineages. Specific genetic events occurs and that leads to the malignant transformation of the stem cells as well as its progeny, and which ultimately leads to the formation of leukemic cells. Acute leukemia primarily originates in the bone marrow. Gradually it replaces the normal bone marrow cells and subsequently enters into the peripheral blood. Basically, there is an arrest of differentiation of the immature cells into the functionally mature cells. In some cases, of course, you may not find the blast cells in the peripheral blood, but there may be a lot of blast cells in the bone marrow. This stage of the acute leukemia is known as the aleukemic stage of acute leukemia. Now, regarding the definitions, according to the World Health Organizations, at least we will have to show 20% of the blast cells either in the peripheral blood or in the bone marrow. In some cases or in some variety of leukemia, other than the blast cells may be counted as the blast equivalent cells. Some examples are the erythroblasts in pure erythroleukemia and promonocyte in monocytic leukemia. Now, the classification of acute leukemia, you know that basically there are two types of classifications. One is the FAB or the French American British classifications. Another is the WHO or World Health Organization classifications. Now the French, American and British classifications, which was formulated in 1976, was based on primarily the morphology of the leukemic cells as well as the different cytochemical reactions. But the FAB classifications was used primarily for the diagnosis of acute leukemia. Now the acute lymphoblastic leukemia, it is a neoplasm of the precursor lymphoid cells, those who are committed to the B cell lineage or T cell lineage. These cells are typically composed of small to medium sized blast cells with scanty cytoplasm, moderately condensed or dispersed chromatin, and inconspicuous nucleoli, involving bone marrow as well as the peripheral blood. In many treatment protocols, of course, a value of more than 25% of the marrow blast cells is used to define leukemia. As I have already told, for the diagnosis, you have to show at least 20% of the blast cells either in the peripheral blood or in the bone marrow. But in some cases of treatment protocols where 25% is regarded as the criteria for the initiation of the treatment. In general, the diagnosis should be avoided when there is less than 20% blasts. Regarding the epidemiology, we all know that it is a primarily of the disease of the children. More than 75% cases occur in children below the 6 years of age. Etiology in most of the cases is unknown. There is an increased risk in children with Down syndrome and other constitutional genetic disorders. Bone marrow is involved in all cases and peripheral blood is also involved. Extramedullary involvement is found in some conditions and there is a predilection to the central nervous systems, spleen, liver and testes. Regarding the clinical features, most patients with B cells acute lymphoblastic leukemia present with evidence of bone marrow failure, that is the thrombocytopenia, anemia and or neutropenia. Total leukocyte count may be normal, may be decreased or markedly elevated. In addition to that, there may be the lymphadenopathy, hepatomegaly and splenomegaly. Bone pain and arthralgia may be a prominent symptoms. T-cell acute lymphoblastic leukemia typically present with high total leukocyte count and often with a large mediastinal mass or in other tissue mass. Now I have already told that FAB classification is mainly based on the morphology and cytochemistry, and on the basis of morphology the blast cells of acute lymphoblastic leukemia may be classified into 3 types, that is the L1 type, L2 type and L3 type. L1 is the predominantly blast cells found in the most of the cases of acute lymphoblastic leukemia. These blasts are small, homogeneous blasts, scanty cytoplasm and indistinct nuclei. L2 blasts are the large blasts with heterogeneous blasts, indented nuclei, one or more nuclei and abundant cytoplasm. In this context, I like to mention that L2 blasts usually found in case of adult acute lymphoblastic leukemia and the prognosis is not so good. Especially you will find in cases of adult acute lymphoblastic leukemia where the Philadelphia chromosome is positive. Another is the L3 blast, that is a large homogeneous blast which has got an abundant basophilic cytoplasm with prominent vacuolations. This L3 blast usually is a rare finding. It is usually found in case of Burkitt lymphomas. And these blast cells, L3 type, usually arises from the mature lymphoid cells. You can see the picture of the 3 different types of blast cells usually found in acute lymphoblastic leukemia. One is the L1, which has got a condensed chromatin scanty cytoplasm, L2 which is relatively large, having relatively abundant cytoplasm and often dominant nucleoli, and lastly the L3, that is the blast cells having basophilic cytoplasm and cytoplasmic accumulations. Now regarding the morphological parameter, usually lymphoblasts are 12 to 20 micron in size. There is a thin rim of pale blue cytoplasm. Sometimes the centrally placed nucleus, one or two nucleoli. Chromatin is coarser than myeloblast. The chromatin pattern is extremely important. In case of lymphoblast, the chromatin is the condensed chromatin, while in myeloblast, the chromatin is more in homogeneous pattern. In peripheral blood smear, the total leukocyte count markedly elevated in about 70% of patients. There may be a thrombocytopenia, neutropenia, and the most important is the blast cells, that is the lymphoblast. In differential count on smears reveal usually between the 40 to 95% of the blast cells. So this is the peripheral blood picture. You can easily identify the normal lymphocytes as well as the blast cells, which is relatively increased in size. The irregular condensation of the chromatin. Sometimes the nucleus is clipped in some places, and some cytoplasm is of course the scanty. Now regarding the bone marrow aspirations and the bone marrow findings, marrow is the hypercellular marrow. May be almost completely replaced by the blast cells. That is the packed marrow. That's why often it may be difficult to aspirate the marrow material when the marrow is packed by the blast cells. Blast cell should be the more than 20% so that the case may be labeled as acute lymphoblastic leukemia. In some books, of course, you will find the criteria is 25%, but according to World Health Organizations, 20% blast cells is the criteria for the diagnosis of any acute leukemia, irrespective of lymphoid or myeloid lineage. In some cases, of course, the lymphoblast have got a cytoplasmic prolongations or cytoplasmic pseudopores, which is known as the hand mirror cells. These hand mirror cells is most often found in the peripheral blood rather than in the bone marrow. So it's a morphological variant of blast cells, which is the hand mirror cells. In some cases, we often need to do in the bone marrow biopsy, refined biopsy, to diagnose the case of acute lymphoblastic leukemia, where the aspiration is difficult and there is dry tag. So this is a peripheral blood picture, of which the picture A is the classical picture of acute lymphoblastic leukemia. You will find a lot of blast cells having condensed chromatin and very scanty cytoplasm. This is the picture usually found in the bone marrow trephined biopsy, where how it looks, the blast cells looks in the bone marrow trephined biopsy in the A, slide A. And in some cases, the blast cells is admixed with the hematogones. These hematogones are nothing but the normal maturing B cells in the bone marrow, and it is a very difficult in some cases to differentiate the blast cells from the hematogone. In that cases, we have to take the help of flow cytometry, where the different antigenic expression is determined to diagnose and to differentiate the blast cells from the hematogones. Now, regarding the cytochemistry, first of all, the blast cells of lymphoid lineage, they show the positivity in the periodic acid SIP cell. This PA stain or periodic acid SIP stains. This is mostly positive in L1 subtype and in few cases of L2 subtypes. L3 subtypes usually vacuoles are positive for fat stain like oil red coal. ALL blast cells are myeloperoxidase negative. So MPO negativity and the block positivity by the PA stain is the cytochemical diagnosis of blast cells of acute lymphoblastic leukemia. In T cell acute lymphoblastic leukemia, the T cell lymphoblasts are relatively irregular in shape and size. There are numerous folding, and they usually show the focal positivity with acid phosphatase. So this is the picture where you can see the PA stain, and it is showing the block positivity in B cell ALL. So this is the picture where you can find the acid phosphatase positivity in case of T cell ALL. These are the red dots usually found in the cytoplasm, and this is the diagnostic feature of acid phosphatase. So this is the picture of acid phosphatase positivity, where you can see the acid phosphatase positivity in the T cells. These are the red dots usually found in the cytoplasm. Now this is about the immunophenotyping diagnosis of B-cell ALL. And this is the most important part of World Health Organization's WHO subtypes, where not only the morphology and the cytochemistry, but also the immunological expression of the different antigen is detected to confirm the diagnosis of B-cell ALL. You see, the lymphoblast demonstrate the positivity with B-cell marker, that is the CD19, CD79A and CD22. In most of the cases, blast cells also show positivity with the CD10, PAX5, TDT and CD22. CD34 and CD20 expression is variable, CD45 expression is weak or absent. But for your practical purpose, you just remember two important immunophenotyping marker, that is CD19 and CD79A, which is required for the confirmation of the diagnosis of lymphoblast and acute lymphoblastic leukemia. Regarding the immunophenotyping of T-cell ALL, T-cell ALL usually express the T-cell marker. The most important is the CD3. CD3, CD5, CD7, CD8. Sometimes there is aberrant expression of CD13 and 33, which is the marker for myeloid blast cells. It is usually found in 20 to 30% of the cases. But for your convenience, you will have to remember only two markers, that is CD3 and CD5 and the CD7. CD3 and CD7, these two markers is extremely important for the immunophenotyping expression of T cells. So this is the picture where you can find the different cytogenetic marker, its molecular marker and the prognostic significance, and it will be required to know the different prognostic parameters. You can easily identify that the first one, that is the translocation 922, that is the BCR-ABL translocation, usually found in the adult case of acute lymphoblastic leukemia, and I have already told that in the adult cases the blast cells are of L2 type and the prognosis is extremely poor. Second is that translocation 1221, the prognosis is good. Third is the translocation 1 and 19, it has got a very bad prognosis. Besides, you can see that hyperdiploidy has got a good prognosis, hypodiploidy has got a good prognosis. So regarding the prognostic significance, as a whole, B-cell ALL has got a good prognosis in children, but has got an unfavorable outcomes in adults. Remission rate 95% in children and 60 to 85% in adults. Nearly 80%. So regarding the prognostic significance, B-cell ALL has got a good prognosis in children, but has unfavorable outcomes in adults. Remission rate, that is a 95% in children and 60 to 85% in adults. Nearly 80% of the children get cured of ALL. Prognosis of T-cell ALL is worse as compared to B-cell ALL. So thank you. I am finishing the discussion about the acute lymphoblastic leukemia, and then you'll have to go through the textbook. And if you have got any problem regarding the understanding, then you can contact me directly.